Dr. Abedede, you can start, sir.
Okay, good evening, consultants, senior colleagues and colleagues. I hope I'm audible, Abi. The task is that
You're audible.
Okay, yes, disease of the aorta. However, I would like to split it into two parts. I will be discussing the acute aortic syndrome this evening, which is three components on the zone. I will be discussing the aneurysm and the aortic aortoarthritis syndrome, maybe later at some other time. I'll be following this particular outline: the anatomy, physiology, the acute aortic syndrome, mainly the aortic dissection and the variant of aortic dissection, the aneurysm and the aortic syndromes, and the primary tumors of the aorta will be at the later date. Yes, by way of introduction, the aorta is the largest artery in the body and is divided into the thoracic and the abdominal component. Now, the thoracic component is divided into the ascending, the aorta, the arch, and the descending segment. Why the descending parts, the descending aorta is divided into the thoracic and the abdominal. The abdominal is further divided into suprarenal and infrarenal segments. Now, the ascending aorta has two main parts: the aortic root, which extends from the aortic valve to the sinotubular junction. Now, the aortic roots form the basis for the aortic valves. They support the base of the aortic valves. And it's also worth to know that the coronary arteries, the right and left coronary artery, pick their origin from this sinuses of valsalva. Now, the upper part of the ascending aorta extends from the sinotubular junction and terminates just before the origin of the bronchocephalic trunk. Now, the initial part, the proximal part of the ascending aorta passes through the pericardium, and that explains some of the clinical symptoms that you find when there's an aortic rupture. They come with cardiac tamponade because of that caused through the pericardium. Now, the aortic arch has supplies. It has the bronchocephalic trunks, the left common carotid artery, and the left subclavian artery that supply mainly the brain. Now, the descending aorta begins shortly after the left subclavian artery. At that junction where the descending aorta link with the aortic arch is called the aortic isthmus, and this aortic isthmus has important landmark. Now, one, the ligamentum arteriosum, which is the fetal remnants of the ductus arteriosus, attached at that spot. It is also a common site for aortic dissection, and also a common site for coarctation of the aorta. Now, the descending thoracic aorta begins just distal to the left subclavian artery, giving rise to paired intercostal arteries at multiple levels of the spine.
Hello, Dr. Abedede. Okay. Dr. Brown.
City, please pause the recording.
At the point of the origin of the descending aorta. Hello, somebody is on down. Which is the junction between the arch and the descending aorta. It's regarded as the aortic isthmus, and this aortic isthmus has some clinical relevance. Now, is the point of attachment of the ligamentum arteriosum, which is the fetal remnant of the ductus arteriosus. It's also a common site for aortic dissection and coarctation of aorta. Also, it also forms the transition between the relatively mobile ascending aorta and the fixed descending aorta, making them more vulnerable to deceleration trauma. Now, distally, the thoracic aorta passes through the diaphragm at the level of the 12th thoracic vertebrae to become the abdominal aorta. Now, the abdominal aorta now gives branches. It gives the celiac artery and the supramesenteric artery anteriorly and the renal artery laterally. Now, the infrarenal segments of the abdominal aorta now lies anterior to the lumbar spine, where it gives paired lumbar arteries posteriorly. Now, the abdominal aorta ends by bifurcation into the common iliac artery. That's at the level of the 4th lumbar vertebra. Now, in adults, the diameters of the aorta varies. Usually, it's largest at the origin, and the ascending portion of the aorta is around 3 centimeters. Now, the descending component is around 2.5 centimeters, while at the level of the descending component, I mean the thoracic aorta, is about 2.5 centimeters, while the abdominal aorta is about 1.8 to 2 centimeters. Now, the arterial wall generally has 3 layers. We have the intima that are made up of the endothelium. Now, we have the tunica media that are composed of concentric layers of elastic fibers that interlace with smooth muscles and collagen. And the outer component, which is the adventitious, they are composed primarily of collecting tissues, enclosing the vascurum and the navi vascularis. The navi vascularis are bundles of nerve fibers that supplies the outer wall of the aorta, and is one of the reasons why it gives pains when there is an aortic dissection, because of they are highly innervated. Now, the media gives the aorta its concentric resilience that resists the hemodynamic stress, while the adventitia collagen fiber governs the tensile strength of the aortic wall. Now, the ascending aorta is the most elastic and distensible part of the aortic tree, and the reason being that it has the highest number of the elastic lamina, about 55 to 60. And this descent, this reduce at it causes along to about 26 at the level of the aortic bifurcation. Now, the direction of the elastic lamina, the collagens and the adventitia with aging make the aorta to be more prone to dissection and aneurysmal formation in those either age group. Now, because of the continuous exposure of the aorta to high postnatal pressure and shear stress, the aorta, they are particularly prone to injury and diseases that result from mechanical stress. Now, checking on the acute aortic syndrome now, which is acute aortic dissection, the acute intramural hematoma, and the penetrating atherosclerotic ulcer. Now, by way of introduction, the acute aortic syndromes are medical emergency with similar clinical characteristics involving the aorta. They have a common pathway for okay. Now, I'll be taking on the aortic dissection itself now. Acute aortic dissection is a life-threatening medical emergency associated with high rates of mortality and morbidity. It has an annual incidence of about 6 in 100,000, with greater than 60% of the deaths secondary to aortic dissection diagnosed as at post-mortem. Now, more than 20% of patients with acute aortic dissection die before reaching the hospital, with more than 50% dying before reaching the specialist center. Now, aortic dissection has a very high early mortality of 1 to 2% per hour of onset of symptoms. That's usually within the first 48 hours after an acute type A dissection. The 2-week mortality rate approaches about 75% in those patients with an undiagnosed aortic dissection. Now, it is reported or documented that aortic dissection is more common in blacks than white, but less common in Asians. Now, it is more commoner in males with a ratio of 2 to 3 to 1. However, women usually present at older ages than men. Approximately 75% of dissections occurs in those aged 40 to 70 years, with a peak in the 6th to 7th decade of life. However, in patients with Marfan syndrome, they present early, usually in the 3rd to 4th decades of life. Now, the pathophysiology and classification. Now, the aortic dissection is caused by a circumferential or less frequently transverse tear of the intima. It often occurs along the right lateral wall of the ascending aorta where the hydraulic shear stress is highest. Now, the other common site is the attachment, just below the attachment of the ligamental acerations to the aortic isthmus, as I earlier mentioned. Now, the initiating effect is primary intima tear with secondary dissections into the media, or a medial hemorrhage that dissects into and rupture the intima. Usually what happens is that there's a tear in the intima that now cause the dissection. The blood now dissects the arterial plane between the intima into the media. And that's what actually gave the true lumen and the false lumen. Now, the pulsatile aortic flow then dissects along the elastic laminar plate of the aortic media, now creating a false lumen. This is separated from the true lumen by dissecting or an intimal flap. Now, the dissection usually propagates distally down the descending aorta and into its major branches, but occasionally it can also propagate proximally. Now, the distension of the false lumen with blood causes the intimal flap to compress the true lumen and narrow its caliber, which may result in malperfusion syndrome, meaning there could be visceral ischemia. Now, this process is followed either by an aortic rupture in the case of adventitial destruction or by re-entering back into the true aortic lumen through a second tear. If you look at this diagram, you can see, looking at this arrow, the second arrow that passes through the first lumen, there was the initial entry and it exits at the other end, being separated by an intima flap. And you can see that the first lumen appear bigger than the true lumen, and this is because of the compression of the accumulated blood within the first lumen compressing on the true lumen. Now, by way of classification, there are two main classifications: the Becky classification and the Stanford classification. Now, the Becky classification is divided into type 1, type 2, and type 3. Now, for type 1, they are usually the one that the intima tear originates in the ascending aorta. Now it propagates at least to the aortic arch and into the descending aortic component. Now, for type 2, the tear originates in the ascending aorta and they are confined to the ascending aorta. Anyone that involves the ascending aorta are regarded as type A of the Stanford classification. Now, why the type 3 of the DeBakey usually originates in the descending aorta and extend distally down to its origin of bifurcation. The type 3 is also divided into type A and type B. The type A are the one in which the dissection is above the diaphragm, and those ones that extend below the diaphragm are regarded as type 3B. Now, these type 3 are regarded as the type 2 because mainly they involve the descending aorta, are regarded as type B. Anyone that involve the ascending aorta, whether it propagates or not, which are type 1 and type 2, are regarded as Stanford type A, while those ones that are involved in descending aorta are regarded as Stanford type B. Now, looking at how frequent those components of the aorta are affected, the most common site for aortic dissection is the ascending aorta. You can see up to 60 to 70% of intimal tear occurring in the ascending aorta, usually about 2 to 2.5 centimeter above the aortic root. 30% of it involve the descending aorta, and less commonly involve the arch, the aortic arch. Now, based on the time course of the disease, the ESC guideline divided into acute, subacute, and the chronic. The subacute are usually less than 14 days, while the subacute ranges between 14 to 90 days. Chronic cases are the ones that lasted more than 90 days. Now, the predisposing factor to aortic dissection. Now, there could be an interplay between the congenital and an acquired factor in the development of an aortic dissection. The genetic causes are those people that have underlying aortopathy, people with Marfan syndrome, Ehlers-Danlos syndrome, Lewis-Dietz syndrome, Turner's and other syndromes. People with congenital cardiac anomaly, that's bicuspid aortic valve, the supraventricular aortic stenosis, coarctation of aortas, penetrating aortic ulcers, metabolic disorder like homocystinuria and familial hypercholesterolemia, inflammatory causes, people with giant cell arthritis, pitychiasis, Behçet disease, and syphilitic aortitis, though this one is a rare cause of aortic dissection. Syphilitic aortitis is a rare cause of aortic dissection. Now, systemic hypertension is also a risk factor. In fact, it's seen in about 70% of patients presenting with aortic dissection. Drugs, people on cocaine, amphetamines, and methamphetamine, pregnancy, especially in people that have an underlying aortopathy. And usually you see most of the cases occurring in the third trimester or early part of delivery. It could be as a result of trauma, either blunt or iatrogenic. Iatrogenic is usually from interventional processes like cardiac catheterization, valvular repair, intra-aortic balloon pump, and those with pre-existing aortic aneurysm are all implicated in the etiology of aortic dissection. Now, the diagnosis requires an high index of suspicion, as no one sign or symptoms can possibly identify an aortic dissection. Clinically, the presentation of aortic dissection is subject to the extent of the dissection, with complaints corresponding to those affected cardiovascular structures. Now, the presence of chest pain with any neurological findings, or if you're having a chest pain with an abdominal pain occurring concurrently, or a chest pain accompanied by weakness in the limbs or paresthesia, should raise an alert that we are dealing with a possible acute aortic dissection. Now, most patients present with chest pain or a back pain. In about 90% of them, they come with classical chest pain. Less than 10% of them can come with a painless aortic dissection. And usually they describe it as sharp, stabbing, tearing, or ripping in nature. Usually has the maximum intensity at onset as compared to other differential diagnoses whose intensity increases over time. Now, some of them can have migratory characteristics that one will occur along the course of the dissection of the aorta. And some patients can present with syncope, stroke, myocardial infarction, or acute congestive heart failure. Now, the painless type, usually they are commoner in Marfan syndrome. And you could also have an atypical presentation in which patient will just come with a pruritic chest pain, burning, or pressure in the chest. Now, the anterior chest pain are more commoner with the type A dissection, while the back or abdominal pain are more commoner with type B. Now, pain in the neck, throat, and jaw or head could predict involvement of an ascending aorta or other great vessels. You can have flank pain in the settings of renal artery involvement. And in the settings of descending aorta, in which dilation involve some of its branches. As I mentioned earlier, some patients can come with all these following symptoms: mesenteric leukemia, lower limb extremity.
We can hear you. We
Hello?
can see your screen. Thank you. Yes, we can hear you. We can
I
see
can
your
go on.
screen. Yes, please.
Okay. Other clinical features at presentation, which could be related to the complications of the disease, include congestive heart failure. Those are the patients that have acute aortic rupture. They can come down with congestive heart failure, seen about 10% of patients. They can come with neurological deficits, especially patients with type A dissections. They can come with coronary ischemia, also in the settings of type A, and these are usually patients that have an involvement of right coronary artery. And some of them can even come with cardiac arrest or even sudden cardiac death. Now, features that suggest compression of adjacent structures, they are dyspnea, dysphagia, or hoarseness, or in the settings of rupture into the lungs. Some patients can present with hemoptysis, and some patients can even have fever, which is usually a systemic manifestation to the ongoing disease process. Now, on examination, usually you see patients, they are anxious, they come in painful distress, they are diaphoretic, they can have pulse deficits, and in about 80% of patients with type B, they can present with systemic hypertension, and 36% of type A dissection can come down with systemic hypertension. However, type A can present with normal blood pressure or hypertension, and those are people that have an rupture of the ascending aorta. They can present with inter-arm blood pressure differences that is greater than 20 millimeter of mercury. Some of them can present with symptoms or signs of aortic agitations, especially in patients that have type A aortic dissection. They can present with findings suggestive of cardiac tamponade. And type A aortic dissection, because of the cause, the earlier cause of the ascending aorta, they pass through the pericardium. They can present with acute pericarditis, can come down with bland pericardial effusion or even cardiac tamponade. And these pericardial effusion, they are usually more on the left side than the right. I think I mentioned this. These are feature of compression. Now, on investigation, there are auxiliary investigation. There are also diagnostic investigation. The auxiliary investigation, usually we start with a chest X-ray, though the finding could be non-specific, and in many cases it can even be normal. However, the abnormality that can be found on chest X-ray are the abnormal aortic contour or widening of the aortic silhouette. You can also see a prior effusion, which is usually on the left. Now, the ECG findings on ECG are usually non-specific. However, they can indicate complication of the disease process, like myocardial infarction. They can come down. You can also find low voltage KRS complexes, which are related to hemopericardium. And ECG changes suggestive of ischemia may be present, especially in type A. So it may be present in either type A or type B, demonstrating a non-specific STT wave changes. And when you are seeing STT wave changes on ECG, is a marker of poor prognostic factor in a patient that has an aortic dissection. Now, we also have hematological tests that could be done. These are either to look at the possible complications of the disease or a guide to differential diagnosis of the disease. Of note is the D dimer, because an elevated D dimer has been shown to give an idea, especially in a patient that have the clinical symptom, a suspicion of an aortic disease. Now, and the pattern of the D dimer is that they are usually elevated in the first hours of the disease, meaning that by the time you are thinking of an aortic dissection and a patient in the first hour or 2 hours of the disease, you are seeing a value that is less than 500, you must think of other possible differential diagnoses. Now, in a meta-analysis assessing its use in the diagnosis of acute aortic dissection, they find that D-dimer value of more than 500 nanogram per mil is associated with 97% sensitivity and 56% specificity. Now, on the diagnostic imaging, now the confirmation of aortic disease can be established using the non-invasive techniques such as the contrast enhanced CT, the MRI, transesophageal, and the transthoracic echocardiography. Now, some of the findings that you can see on those radiological imaging are: one, it must be able to identify the intimal flap. It can tell you the anatomy that is involved. It can tell you the extent. Some of the findings that you can see on diagnostic imaging, apart from the intimal flap, it can give you an idea of the anatomy that is involved. It can give you the extent of the disease. It can give you an idea about the presence of pericardial effusion, the arterial territory that is involved, and the site of entry and exit of the blood flow. Now, looking at the sensitivity and specificity of those non-invasive imaging modality, the sensitivity for CT and the MRI are the highest compared to transthoracic and transesophageal, as well as the specificity is also highest for the CT and MRI, as well as the transesophageal. Now, for transthoracic, using the standard M mode and 2D echocardiography, now you can see the presence of an intimal flap. If you look at the attached image below and looking at that arrow, you see this echogenic materials within, almost closer to the aortic valves. Those are intimal flaps seen on transthoracic echo. Now, the transthoracic echo has a good sensitivity if you are trying to look for type A aortic dissection of about 85%. However, it's not good in picking the type B aortic dissection. Because of that, those are the limitations of transthoracic echo in the diagnosis of aortic dissection, because a negative findings on transthoracic echo does not mean that a patient does not have an aortic dissection, especially if he has the descending type. Now, this is also an image showing an echo. If you look at the first image, there is this echogenic material or echogenic flap very closer to the aortic valve, and that's why on color Doppler it gives regurgitations because of the dilatations of the ascending aorta. Now, transesophageal was able to overcome the limitation of the transthoracic and is of great interest in those people that are unstable, patients with hemodynamic compromise, because they have an advantage of being able to monitor changes intra-op and post-operatively. Now, it has a better accuracy in terms of evaluation and diagnosis of acute aortic dissection with a sensitivity and specificity that is up to 95%. Now, it can detect an intimal flap with a differential Doppler flow, which I will show next. If you look at this attached image, you will see that echogenic worm-like materials. Those are the intimal flap. Can also give you the presence of a thrombus in the first lumen. Now, the features of true lumen on transesophageal are usually they are smaller with systolic expansion. They show systolic and anterograde flow. It shows early and fast contrast enhanced echogenic flow, and they communicate with the true lumen in systole. If you look at this, this is a color Doppler flow in a patient that has an aortic dissection. You can see this differential echogenic Doppler flow showing that the true lumens, there is passage of blood through the true lumen, while there is little or no flow within the first. Also see that echogenic material is the most commonly used imaging techniques for evaluation of aortic dissection, showing two distinct lumen with a visible intimal flap. The first lumen usually has a slower flow and a larger diameter than the true lumen, and the reason being that the blood flow compress or distend rather the first lumen. Now, the sensitivity and specificity of contrast enhanced CT is up to 98%, even up to 100% in certain instances. Now, the major limitation of CT are just the complications. Some patients can react to contrast, and some can even come down with contrast in this nephropathy. Now, if you look at these images, the one on the left is showing the ascending rather, with the dissecting flap. This is the ascending, this is the descending aorta. And this is the descending aorta. This is the dissecting flap. Now, if you look at the second image, you can see the first lumen, which is far, far bigger than the true lumen with a dissecting flap. If you can also look at the descending aorta, it also has a first lumen, which is far bigger. They are hyperdense area with a far bigger lumen than the true lumen. The same thing, and this is usually described as tennis ball sign. You can see the intimal flap dividing the first lumen and the true lumen. This is described as tennis ball sign. You can see it both in the ascending and the descending aorta. Almost the same image. However, but the second image, apart from the true lumen, the intimal flap, they also have this. It has this hypodense lesions. This well circularized hypodense lesion within the surrounding the ascending aorta, which is suggestive of an hemopericardium. Now, the MRI is less often used for initial evaluation of acute aortic dissection, and it's because of the longer scanning time, the contraindications to the metallic implant, and the less overall availability. The sensitivity and specificity is also very good, like that of CT. Now, however, in those patients, gadolinium contrast must be used with caution in those patients with reduced kidney functions because of the risk of nephrogenic systemic fibrosis. Now, the non-contrast enhanced MRI may diagnose aortic dissection when gadolinium contrast is contraindicated. Now, if you look at this image below, you can see this. Hello.
Hello, we can hear you.
Okay, you can see this transverse plane at the level of the aortic arch. The true lumen is the one at the upper part, while the first lumen is the lower part with a separating intimal flap. Now, the aortography is used less commonly now because it's more invasive and because of the better sensitivity and specificity of the non-invasive diagnostic imaging. Now, this is the ESC recommendation when you are evaluating a patient with a suspected aortic dissection. Transthoracic echocardiography is recommended as the initial imaging investigation. It's a class 1 recommendation. In those patients that are unstable, is a class 1 recommendation to make use of transesophageal echo or the CT, depending on availability in your area. For stable patients, CT and MRI take precedence, though they take precedence over transesophageal with the class 1 recommendation. Now, in those patients with uncomplicated type B aortic dissection, okay, I think I've not gotten it. I'll get there. Okay. Now, as regard treatment, now patients require an ICU admission for hemodynamic monitoring. The initial task when you are seeing those patients are stabilizations, hemodynamic stabilization, pain control, and the lowering of blood pressure. In order, unless there is a contraindication, beta blockers are usually the first line drugs. Usually it's given parenterally, and our target is an heart rate of 60 to 80 beats per minute. Beta blocker of choice could be labetalol, metoprolol, or esmolol. Now, in those patients who has not achieved or whose blood pressure is more than 120 millimeter of mercury, one can additionally make use of intravenous sodium nitroprusside with a target systolic blood pressure of 100 to 120 millimeter of mercury or higher, or lower rather. Now, these are the likely medication that can be used in a patient that has an aortic dissection. Beta blockers, I said earlier, are the first line. In those patients that have contraindication to beta blockers, you can make use of the non-diapyridine calcium channel blockers, the thiazide and verapamil. These are other vasodilators that can be used in patients with a higher blood pressure. I think I've mentioned all this. As regards pain management, narcotics and opioids are the preferred agents. Usually morphine sulfate is preferred. Uh, uh, cautions, however, should be exercised in a patient that has an aortic regurgitation because it can block the tachycardia. On such, in those patients that are suspected, knowing that for type A aortic dissection and those patients with complicated type B, and those are the patients that are coming with features of visceral ischemia, patient with shock, emergent or surgical corrections are class 1 recommendation in such a patient. Now, in those hypotensive patients who could be attempted. Now, vasopressor can be added in order to maintain the perfusion, but caution should be exercised as this can cause further propagations of the dissection. Now, ionotropic agents should be avoided as this can increase the force and rate of ventricular contraction, thus worsening the dissection. Now, pericardiocentesis in the settings of an acute hemopericardium in patients with cardiac tamponade requires some cautions, as these can result in worsening of the bleeding and acute hemodynamic compromise. And it has been shown that a patient that has type A aortic dissection with tamponade, that surgery gives a better outcome than those patients that has pericardiocentesis. However, in some patients that are unstable or they cannot undergo surgery, one can cautiously attempt to remove small amounts of the blood within the pericardium in such instances. Now, for the surgical management, it involved the excisions of the intima flap, the obliterations of the entry and exit into the first lumen, reconstitutions of the aorta with interpositions of a synthetic vascular graft. Now, overall, in overall in-hospital mortality rate after surgical treatment of patients with type A is reported to be about 18% compared to 56% in those patients that are medically treated. Now, in the International Registry of Aortic Dissection, they reported 26% mortality post-surgery compared to 58% in those patients that are medically treated. Now, the major causes of perioperative mortality and morbidity include myocardial infarction, paraplegia, tamponade, sepsis, and others. Now, indications for TEVA or open surgical repair in a patient with type B are the following: patient with rupture and impending rupture, patient with visceral visceral ischemia, patient that have refractory pain, refractory hypertension, aneurysmal dilatation that is more than 50 mm, progressive aortic enlargement of more than 5 mm per year, or recurrent symptoms. Those are indications for surgery in type B aortic dissection. Now, for the uncomplicated and the stable type B dissection, medical therapy is the recommended treatment. Now, for type B aortic dissection, they have a lower mortality compared to type A, approximately about 10%. It's about 1 to 6% in those that have uncomplicated type B, but tends to be more higher in those that have complicated type B aortic dissection. Now, these are ESC guideline on management. As I said earlier, class 1 recommendations, medical therapy, and these include pain relief and blood pressure control are recommended. Urgent surgery in type A. For uncomplicated type B, medical therapy is recommended therapy. That's class 1 recommendation. For the complicated type B, as I said earlier, surgery is recommended. Now, as per long-term management of patients that have an aortic dissection, that have had a repair, or those type B, they're uncomplicated type B, these are what are expected to be done in those patients that we are being followed up, and this entails the good control of blood pressure, serial monitoring of the aorta, screenings of the relatives of patients, looking for the heritable causes of an aortic dissection, lifestyle modification, education and psychosocial support. Now, our target for BP control in long-term management is 120/80. Usually, the first choice is beta blockers, but in those that doesn't have a good control, other antihypertensive can be made use of, and these include AC inhibitors and calcium channel blockers as required. Now, for surgery, it is recommended that the imaging should be performed at 1 month post-surgery. Post-surgery, 1 month, you have to do a repeat imaging to look at the aorta, while the subsequent one will be done at 6 months, 12 months, and then yearly, depending on what it's as and. Now, and this is a class 1 recommendation, and CT is regarded as the first choice imaging techniques to follow up patient post-surgery. Now, for chronic type B, those ones that are primarily receiving medical therapy, surveillance will be at 6 months after initial diagnosis. Now, progressive descending aortic enlargement that is more than 5 to 10 mm per year, or diameter that is more than 55 to 60 mm, they are risk factor for ruptures, and such patients should be evaluated for repair. Now, smoking sensations and modifications of atherosclerotic disease risk factors should be done. Patients should be advised to avoid competitive and body contact sports, as well as heavy weightlifting should be discouraged. Leisure sporting activities can be encouraged. Now, because some of those patients that has dissection, they have all this post-traumatic stress disorder, anxiety disorder, and depression, they needed some psychotherapy. And post-surgeries, most patients will require the rehabilitation therapy. that will allow them to go back to their normal usual activities. Now, the prognosis for those patients that are treated for dissections is generally good. They have a 10-year survival of up to 60%. These are markers of prognosis in those patients that has an acute aortic dissection, shocks, abnormal ECG, especially ST elevations. Those are the poor prognostic marker in them. Now, chronic aortic dissection. Now, there are two variants of this. Those patients that have an earlier dissection that were managed, that were now following up at the clinic, and those are the one I discussed earlier. However, there are some that you only pick them incidentally. They are asymptomatic. Pick them incidentally, maybe because of the chest X-ray or other imaging modality. In such patients, what we are interested in is looking at the features of an enlarging dissected aorta. Patient come with ulcerness, dysphagia, features of visceral malperfusion, patient coming down with current abdominal pain, altered renal functions, or recurrent chest pain that could indicate either an impending rupture or worsening of the earlier dissection. Now, the features that you can actually see on those patients that have a chronic aortic dissection include a thickening rather than the initial mobile. In acute, they're usually mobile. This one, they'll be thickened and they'll be immobile intima flap. There could be thrombus within the first lumen or aneurysm of the thoracic aorta. These are indication for this is indication for surgery in those patients. The chronic type A aortic dissection, patient that are symptomatic, patient who has an aortic aneurysm that is more than 5.5 centimeter. Those are indication in those patients that we pick them incidentally and we now find this on their imaging modality. Now, in those chronic aortic dissection, CT and MRI are still the first line imaging modality in following them up. It's still the first line imaging modality. Our target for BP control in that setting are less than 130/80. And surgery can be done in those patients that has an aortic diameter that is more than 60 mm or annual increase that is more than 10 mm, or a patient that have features of malperfusions. Now, going to the variants of the aortic dissection, because they usually have similar clinical features, some of them share similar clinical characteristics. They can present in a way that is similar to an aortic dissection, and usually they are the intramural hematoma and penetrating aortic atherosclerotic ulcers. They are under the same acute aortic syndrome. In fact, in some of them, they can even coexist in some patients. Now, the only difference between them is the pathophysiological mechanism and the imaging findings that you see in such patients. For those with intramural hematoma, the risk factor is not different from the typical aortic dissection. However, patient with penetrating aortic ulcer has coexisting or pre-existing cardiovascular risk factor like hypertension, diabetes, and all those ones. Now, acute intramural hematoma is defined as hematoma within medial layer of the aortic wall in the absence of an identifiable communication between the lumen and the hematoma, and there's no evidence of an intima flap or first lumen as compared to classical aortic dissection. This represents about 10 to 20% of the acute aortic syndrome. And if you look at the anatomical involvement, we are comparing them with the classical aortic dissection. I said earlier that the ascending aorta for classical aortic dissection is about 70%, but in this instance, the ascending aorta involvement is about 30%. It's always the reverse of an aortic dissection. The descending here is up to 60-70% in comparison to the classical aortic dissection. Now, it usually results from rupture or the vasa vasorum in the adventitia and the subsequent molar hemorrhages into the tunica media. The hematoma is usually located on the outer medial wall in contrast to the medial location of the classical aortic dissection. And if you look at this pathophysiology, using this diagram, I've shown the first one earlier. There is a tear with an arrow showing the direction of flow. This one, there is an hematoma, but there's no evidence of communication between the two. And there is no intimal flap. It's just the hematoma that is bulging into the aortic lumen. And if you look at this, the penetrating aortic ulcer usually is an atheromatous plaque with an ulcer that penetrates through the intima into the media of the aortic wall. Usually, too, it doesn't have usually an hematoma, and it will be compressing on its true lumen. Now, the proximity of the intramural hematoma to the adventitia explain the frequent coexistence of the pericardial effusions, the pleural effusions, and this underlines the higher risk of aortic rupture that you notice in intramural hematoma. They are also classically divided into type A and type B, like the classical aortic dissection. The ascending one, which is the type A, because of they can come down with aortic regurgitation, hemopericardium, or rupture, but malperfusion syndrome is less common in them. Now, the imaging modality is not different from the classical aortic aneurysm. It's not different, but the sensitivity of the transthoracic is low. Now, intramural hematoma, on imaging, what we are going to see is a concentric thickening of more than 5 mm of the aortic wall in the absence of a detectable blood flow and intimal flap. And most of the intramural hematoma are easily diagnosed on non-contrast CT imaging, showing concentric high attenuation within the aortic wall. Now, the combinations of the non-enhanced acquisition, which is non-enhanced contrast CT, followed by contrast CT, usually yield the sensitivity that is up to 90% in the detection of in acute intramural hematoma. Now, if you look at this, the first image, look at this blue pointer. You can see these hypoechoic wall thickening that's overlining or just before the hyperechoic aortic wall. This is usually, it's based on this, is more than 5 mm thickened, and this is type A intramural hematoma. And because of the accompanying dilatations, the patient come down with aortic regurgitations on Doppler image. If you look at the second image, you can see this is well demarcated. You can see the arrow showing this. That's on the transesophageal rather, showing the area of hematoma on the intima of the aortic wall. This is a CT showing the concentric hypodense lesions around the ascending aorta. You can see that white arrow up is that area of the lesions. This one I'm showing is the area of the intramural hematoma. This is a esophageal echo showing this area of hematoma within the aortic wall. This is MRI. You can see this hyper intense around the ascending aorta. You can see based on this arrow, and you can see it going down even on the descending aorta with this arrow showing this. Now, the predictors of intramural complications are the presence of persistent or recurrent pain despite aggressive medical treatment, difficult blood pressure control. When you have an aortic diameter that is more than 50, yearly we have progressive maximal aortic wall thickness of more than 11. Now, recurrent pericardial effusions, all these are features of intramural hematoma complications. As this is ESC recommendation, all patients with intramural hematoma, medical therapy, including pain relief and blood pressure control, is recommended. For type A, urgent surgery is indicated. For uncomplicated type B, medical therapy is indicated. For complicated one, they also require surgery. Now, for penetrating atherosclerotic aortic ulcer, these are atherosclerotic lesions with ulceration that penetrates into the aortic wall. They are usually localized and they are not associated with an extensive propagation like the other variants. This represents about 5% of the acute aortic syndrome. It may be single, the aortic ulcer may be single or multiple and ranges from 5 to 25 mm in diameter and 4 to 30 mm in depth. They are found primarily in the distal descending aorta than the arcs or abdominal aorta, and rarely you see them in the ascending aorta. They are typically older patients with coexisting cardiovascular risk factor. 25% of them are peak incidentally on imaging. Penetrating aortic ulcer may lead to aortic dissection. Most patients do not have aortic regurgitation, pulse deficit, or sign of organ perfusion. Now, propagation of the ulcerative process may either lead to intramural hematoma, pseudoaneurysm, aortic rupture, or an aortic dissection. In terms of aortogenesis, there is an existing atherosclerotic plaques that erode through the intimal layer of the aortic wall into the medial layer, and this results in a direct communication between the aortic lumen and the medial layer of the aortic wall, usually with an associated intramural hematoma. They are not actually exclusive of each other. They can coexist and one can actually lead to another. Now, the diagnostic imaging is not different from the classical aortic aneurysm. Now, contrast enhanced CT is the imaging technique choice for the diagnosis of penetrating atherosclerotic ulcer. Findings on CT include localized aortic ulcerations, calcified or displaced intima, or coexisting intramural hematoma or aneurysm. Now, predictors of disease progression in patients that have aortic ulcers are increasing aortic wall thickness. When you have ulcer crater that is more than 50 to 20 mm in diameter and greater than 10 mm in depth, increasing aortic hematoma and the presence of increasing pericardial effusion. Now, what you see on their CT is usually focal outpunching of contrast into the wall or beyond the wall. If you look at this arrow here, the CT imaging, you can see as if something is pointing, as if there is a, sorry, those arrow pointing, as if there is something pointing down, is the focal outpunching of the aortic wall. And the same thing in the other image too. You see there's an outpunching of the contrast into the wall, which are suggestive of an aortic ulcer. As regards management, it's also medical. It's a class 1 indication, pain relief management, blood pressure controls. Type A is managed like the other component of the aortic syndrome. For the uncomplicated type B, they require repetitive imaging. For complicated type B, the TEFL should be considered. And in complicated type B, surgery may be considered depending on the situation. These are the references. I will be presenting the other component at a later date, which is the aortic aneurysm, the aortic syndrome. Thanks for listening.
Dr. Adedede, thank you so much for your lucid presentation. Don't mind the network that was coming in between. to ask. I was thinking that the other ones will come tomorrow. You said at a later date.
It's not tomorrow, ma'am. Please. I will do it
Okay, but is this
1 hour before weekend. I'm still on it. Hello, ma'am.
hello? Is that on or before the end of the week, right?
Yes, I will do it all before the end of the week. I will complete it before weekend.
Okay, thank you so much. Once again, this is an excellent
I will let you know
presentation.
when I'm ready. Yes, ma'am.
Okay, thank you so much for
Thank you.
taking time to prepare the slide.
Yes, ma'am.
Chief, sir, the platform is open for questions, contributions, as concerns what we've listened to in the last 1 hour or so, 1 hour, 10 minutes. So this contribution has a hello, was I audible? Any comments or contributions? Please, am I audible? I need to confirm.
Yes, ma'am.
Thank you so much, Dr. Subi, for that. I was thinking that I need to get to the mango tree myself. Thank you, sir. Please, any comments or contribution to what we've just listened to? Okay, Dr. Deji, it seems as if there are no.
Okay.
Thank you so much once again for putting the slides up and for taking your time to take us. We are very grateful. And from the chat box, everybody is saying thank you, thank you, thank you. So thank you once again. Yes, we are grateful.
Yes, ma'am.
Yes. So without wasting much time, we'll quickly go to the other parts of the sessions that we have this evening, and that will be the subspecialty recall. We did not do two yesterday. That's one by Chief Ayodeji and by Dr. Itubi. So we'll be starting with both Chief Ayodeji, who is taking